ophthalmic aneurysms. No conflict of interest, of course. How we decide between the clip and coil? It's fairly easy. The more blood in the subarachnoid space, the more we go for endo. Of course, the worse the WFNS score, the more we go for endo. The older the patients, again, more endo. And the more medium-sized aneurysm, because the huge aneurysms and really small, like blister ones, we still feel that surgery is better. And in ophthalmic aneurysm, there is another aspect, which is the more drilling is needed, the more we go for endovascular. And although the more the aneurysm is located below the optic nerve, the more we go for endo. So this is simple rules, which are, of course, not dogmatic, but which we somehow keep in mind and decide individual. Over the past 10 years, we have had 150 ophthalmic aneurysms. Endovascular treatment was done in 106, so only in 42 we went for surgery. And this is the same ratio which we have in all the series of more than 2,000 aneurysms now, that 30% of the aneurysms are treated surgically and 70% by endovascular means. And we are happy with endovascular surgery by all means. So I don't really care whether the aneurysm is treated endovascularly or surgically, because what's important is the outcome. Should the patient be all right, then it's perfect by any means. Should the patient be in a bad condition, then any treatment is, of course, wrong. The only unfortunate thing about this is that in the decision-making process, you know that you've made your mistake only after. With the hindsight, you realize that you made a mistake. There is also a combination. This one an aneurysm which I clipped, and I was not really satisfied because I was unable to see the tips of the clip. So we went immediately to the OR, to the angio suite. This is 15 minutes after the last stitch, and we called the aneurysm. I'm not sure whether this was good thrombose or not, but this was rather elegant approach. Surgically, there is no inaccessible region in the brain. You may see nearly the whole circle of Willis from one single pterional craniotomy. This is like that. But for ophthalmic aneurysm, you really need just this small region where is the optic nerve and where is the carotid artery entering the intradural compartment. And this is the most rewarding surgery because it's like 10 minutes intradurally and you are done. This is a simple ophthalmic artery aneurysm just below the optic nerve, which is on the left-hand side, no retraction whatsoever, no dissection of the Sylvian fissure, no dissection of anything else except chiasmatic and carotid cistern. This is done like that, and this is the best advantage against the endovascular. As Juha says, you can kill the aneurysm, and you may be sure that the job is done. And if I overdo it, you may tell the patient, do not see him again. There are no recurrences after this. What were the techniques in these 42 cases? Proximal control, there was none in 37. I do not know whether it was my bravery or stupidity. In one case of large aneurysm, we dissected the carotid in the neck, and in 4 cases, we have used the balloon. The last was the unfortunate case when the radiologist put the balloon by mistake on the opposite side carotid, and when the aneurysm ruptured, then really the was very, very significant. What about the drilling? There was none in 16 cases. It looks like the one I have shown you already. Sometimes only the coagulation of the dura just lateral to the optic nerve and medial to the carotid artery is sufficient to insert the clip. Targeted drilling in 15 cases, I will show what it looks like. And the whole anterior clinoid only in 6 cases and only in large aneurysms. I don't think that one really needs that at majority of cases. So surgical technique, this is simple craniotomy, but it really doesn't matter whether you go supraorbital or frontolateral or pterional. In my mind, the large craniotomy or the regular size craniotomy gives you different angles of sight and much more maneuverability than the supraorbital approach. And this is what you need to see. This is the optic nerve, this is the carotid artery, and you do not need to dissect anything else. This is from below. This is the optic nerve here, the carotid artery. This is from our study on cisterns. And you really open only the optochiasmatic cistern and carotid cistern. Nothing else, no dissection is necessary. So let's go to a few cases. This is a happy lady with 2 aneurysms on carotid artery on both sides. This one was treated endovascularly and this one surgically. And again, this was very straightforward procedure, very similar to the first one. You see that there is space enough between the aneurysm and the optic nerve to insert the clip. Thus, everything you need is only to dissect the distal part of the neck, and then you may clip the aneurysm and then coagulate it. These are really probably the best surgeries, and they definitely are easier than the PCOM aneurysm, because these are above the carotid. These aneurysm PCOM are mostly below, so you do not see the aneurysm that well, as opposed to these ophthalmic aneurysms, which are really perfectly accessible and seen on all sides. Check of the blood flow, of course, is necessary. This is after. This is another one. Again, there is no drilling necessary in this case. And oops, yes. And the only dissection again is the optic nerve, the optochiasmatic cistern, the carotid cistern. Then you are directly on the aneurysm. And the only question is whether you will need to drill the clinoid or part of the clinoid or not. And in the majority of cases, you really do not need it. At least in half of the cases, you do not need it. And a good CTA prior to surgery should show you whether the aneurysm is covered by bone or not, and you can predict the need for drilling. And if there is a need for drilling, as I told you already, we really prefer endovascular treatment to surgical treatment. So this will be exactly the same as the first case. So let's skip that. This is after. It's like a carbon copy of the first case. This is the CTA, and you want to check the tuberculum cellae and anterior clinoid, which really tells you whether the drilling will be necessary or not. And again, even with drilling, you do not need too much space. You need to uncover the upper ring and then resect it. And Mustafa has said, falciform ligament. So you start your drilling medial to the optic nerve, and you go only lateral to the carotid artery. You do not need to expose the lower ring, and you do not need to cut the lower ring, because there is the danger for the third nerve. The opposite is true for really paraclinoid aneurysm, as Mustafa has said. So this is the drilling, the red part. The most important is, of course, optical strut, because this allows you to get anterior to the carotid artery. And this is what you use when the aneurysm is large, because then you need, again, different angles of approach, and you need to see more, and you need to gain some space. The drilling is extradural, because this is unlike in meningiomas. The aneurysm is always covered in dura. So unless you penetrate the dura, you cannot harm the aneurysm, and you use the dura as cover. So you start your drilling lateral to the carotid, and you end it medial to the optic nerve. And here is the region of optical strut where the drilling must be more extensive. You do not need to drill the clinoid process, which is here. So let's see one of those aneurysms with the drilling. It run. It does. So this is already partly resected. The clinoid process, the tip of the clinoid process is untouched. Here is the posterior part of the aneurysm. Here is the carotid artery. So what you need now is only to uncover partly the distal aspect of the neck, and then cutting the dural ring, separating the optic nerve from the carotid artery and the aneurysm. Here is the optic nerve, here is the aneurysm. I sometimes leave piece of the dura on the aneurysm because it doesn't matter, since you anyway need to go underneath and to uncover the neck where there will not be dura. And quite frequently in these aneurysms, you need multiple clips, and you might try several types of clips and several angles of approach. What I really like is to reconstruct from above. So this is the first clip which occludes the aneurysm only partly. And here is the region of optical strut where the drilling is really needed to see the anterior band of the carotid artery, and you see that there is a little remnant of the aneurysm anterior to this first clip. So there will be the second clip. Here is the mother artery, the carotid artery. You perfectly see the wall of the aneurysm starting from the carotid artery, so you can really put your clip very precisely. You can see it from the both sides because you are coming from above, and you can move the aneurysm. If you have a well uncovered optic nerve, you can move the optic nerve. You may not be afraid of these movements. So this is the second clip, which is anterior to the first clip. Then the third clip, and fourth. So this aneurysm was treated by 4 clips, and that's rather frequent that you need to use more clips for the ophthalmic aneurysm. You see, this is the third that you can put it really directly on the neck in this region, and the fourth clip will be already angled from posterior like that. And you see that the dural ring is left on the aneurysm. It's not necessary to dissect it, and it's just calling for the rupture. So this is it. Then you check it with ICG. Do we have it here? I guess yes. Okay, that's it. And you see the nice flow through the carotid artery, and you see that we are just at the origin of the PCOM. Nothing more is needed. And this is the post-op angio, which really shows the preservation of ophthalmic artery and the nice occlusion of the carotid neck. Another similar aneurysm, which looks really difficult. This is the optic nerve, and the optic nerve is split directly on the dome of the aneurysm. It will be better seen a little later, but it really, the optic nerve was nearly transparent, and the lady really, the patient came with visual disturbance, of course. That was the reason for surgery, and we wanted to decompress the optic nerve. And when I saw this, I saw that the patient will be blind after surgery. You will see soon what it looks like. So here we have the tractus, we have the carotid artery here. Here is the dura coming from medial to optic nerve, lateral to the carotid artery. Here is the tip of the clinoid process, which is definitely left behind. If you cut the dura and reflect it on the aneurysm, you may use this flap as some protection of the aneurysm during the drilling. And this is not time for drilling extradurally, it's easier intradurally. So you must remove all the cottonoids from the wound, because it will be 100% sure that you will get your cottonoid on the drill. And you see that there is no retraction, no spatulas, no dissection of the Sylvian fissure. It's just direct approach down to the optic nerve and the carotid artery. And again, this is drilled most anteriorly in the region of optical strut. And in this case, I really went quite far along the optic nerve, more than necessary, because of the compression which was caused by the aneurysm. You may use the bone Cusa should you want. It's exactly the same. I just prefer the diamond drill, which somehow I feel is easier and safer, because it doesn't push you to force everything. And this is the dural ring, which is cut, and you go laterally to the optic, to the ligament. You cut the dura. In this case, we took the dura out. This is the point where one should really be careful, because there is the carotid artery is rather close. Of course, since it's dural ring, you see the carotid artery below the aneurysm here, and then you turn to the optic canal and you decompress the optic nerve and resect the whole piece of dura, exposing the aneurysm. The optic nerve is to the left, still split on the aneurysm. All the time checking for the neck of the aneurysm, at least for the distal part of the nerve. Now we are on the optic nerve, which is over here already. This is falciform ligament now being cut and then going back to the dural ring of the carotid artery. And as soon as it's resected, the whole area gets very nicely exposed. You see the optic, you see the carotid, you see the ophthalmic artery, you see the aneurysm, you see the neck, the posterior part of the neck, the anterior aspect of the neck, and you see the bend of the carotid artery in its clinoid course. So this is a very, very nice approach and sufficient for any clipping. Now this is the last remnant of the dural ring. Sorry for my finger in the field, but I didn't already have the energy to edit the video more. And you see the optic nerve, how it's split on the aneurysm neck, but now it's nicely exposed. Here's space enough for the clip, which I've inserted after trying to dissect the optic nerve from the sac of the aneurysm, but it was virtually impossible because it's really completely flat. Sometimes one sees that in the vestibular schwannomas in the sevens, and I really thought that the patient will be blind after surgery. Then we put the clip. Let's wait for that because there is another interesting aspect of the clipping. You see the posterior aspect of the neck. Here you see the bend of the carotid artery in its clinoid course. And here is the aneurysm, which is rather patient with us and doesn't rupture. And here will be the first clip, which seemed very sufficient and very nice, and which we controlled with the ICG. Again, you have lots of angles with this approach. If you come from perional, you do not fight with your clip applied, you do not fight with your suction. You really have enough space and enough vision and enough angles of vision of everything. That is why I prefer really regular perional craniotomy against the mini approach through the eyebrow. And you see now I again tried to dissect the optic nerve from the aneurysm. It again was practically impossible because you do not know where the optic nerve ends here, if this is only arachnoid or if this is already, if there is already some split neural tissue. So at this point we checked the flow in the aneurysm with the ICG, and it looked perfect. You will see it shortly. The ICG, that's it. You see that the aneurysm doesn't fill. You see the nice vasculature of the optic nerve, even as it is split on the aneurysm sac. So I wanted to decompress the sac, punctured it, and you see that despite the ICG, there is very nice bleeding from the aneurysm. So it means that one shouldn't depend on any technique. This may lead you wrong. So what was necessary was another clip. You see the jet of the blood from the aneurysm. So it means that this clip doesn't hold it sufficiently. So another clip, and that did the job. And after this, I will go forward. And this is the final image when I cut the aneurysm, decompressed the aneurysm, and the optic nerve somehow went back to its normal shape and normal position. And surprisingly, even with this manipulation, the vision returned to normal within the next 2 months. This is the post-op angio. These are another large aneurysms which may be clipped. And again, in this case, you need to see the aneurysm from different angles, from different approaches. You need to see the infraclinoid process. And then sometimes one clip is sufficient, but most frequently not. And most frequently the clip in these aneurysms slips either on the mother artery or out of the aneurysm. So it takes some time to get the best position of the clip, like in this other case. There are also other cases like this aneurysm, the dissecting one, which we didn't know what to do at all. So we trapped the aneurysm, and then you really need the bypass techniques. I don't know if Chuck is still present and if he would comment on this aneurysm, whether he would be able to treat this endovascularly, but we treated by simple trapping and high flow bypass. The outcome in these patients was very good in almost all. These were all ophthalmic aneurysm. There was one bad outcome with hemiparesis, but the hemiparesis was due to ruptured PCOM aneurysm. Hunt has 3 and Fisher 3. Then one in vegetative state due to ruptured ACOM aneurysm. Hunt has 4 and Fisher 3. And one patient died. That was the most unfortunate. This gives altogether 7% morbidity mortality rate. And this is the patient who died. That was 73 years old lady with this partially thrombosed aneurysm. That's quite a long ago. And we went for coiling. We put the coils in. And most likely when the aneurysm thrombosed within the sac, it extended more pressure on the visual pathways, and immediately after surgery or few hours after surgery, the very fast and progressive visual deterioration appeared. So we went for emergency surgery, which was really difficult. We somehow managed, but it didn't help. And after surgery, the patient further deteriorated and died some 2 weeks after the procedure. So this was really unfortunate. So in conclusion, for ophthalmic aneurysm, there's easy access. It's really very straightforward and very easy. No retraction at all is needed. The proximal control, whether you achieve it by endovascular means or by exposing the carotid artery on the neck, or whether you would be doing those without, those which are not necessary for drilling, I don't think that it's necessary. You should have your adenosine at hand should you need it, and should you need a short cardiac arrest. Minimal drilling, don't drill the clinoid unless it's really necessary in large aneurysms. On the other hand, as in any aneurysm, you need the bypass techniques, and be prepared that you will use multiple clips. And don't forget that there is always endovascular option. Thank you very much.
Thank you, Vladimir, as usual. And we open the venue to take 1 or 2 comments, if any. Wonderful presentation.
Imad, 1 comment.
Yeah, go ahead.
Vlad, do you prefer to drill extradurally or intradurally in ruptured versus unruptured paraclinoid aneurysms?
It doesn't matter whether they are ruptured or unruptured. When the aneurysm is large, say more than 12 millimeter in diameter, something like that, then I drill extradurally, and then I drill the whole clinoid process. If the aneurysm is unruptured, small, and I know it's covered by bone, then I drill selectively and intradurally.
Okay.
Any other questions? Any other comment?
May I?
Go ahead, Giovanni.
Compliments, Vladimir, for this presentation and for your skill in dealing with these aneurysms. They are not so simple often. Last slide, you say, remember always an endo option. I will suggest to use always a possible option. Because I know, they tell you, because I personally have a patient with a bilateral aneurysm, carotid ophthalmic aneurysm. One was done endovascular, became blind, and the patient said, do what you want, but I don't want this kind of surgery. So when the optic nerve is, as you showed, is deformated by the aneurysm, I don't think that endovascular is an option, because it will never shrink the aneurysm. Although Moret is not more present, but
Not more with us.
that is the problem in the vascular.
It's not true.
Well,
I am here.
Giovanni, we now have a series of some 2,500 aneurysms since 2000. And since 2000, we have routine endovascular service 24/7. And in 3 surgical cases, I just, let's say, dissected the aneurysm. And I said, I can do nothing. I really left as it was, closed the wound, and we went for endovascular treatment. In neither of these 3 cases, the endovascular guy was able to do anything as well. So it's perfectly, as you said, possible. Not the option, but possible option. Fully agree.
I want to see, I think Dr. Jacques Moret is still here. And the other things you see, I just want to ask Dr. Moret, when they do such a large or giant aneurysm, they are still having the concept flow director with overpacking. The problem was with these giants, the overpacking with coil, so they will never shrink. And many of the cases seen on video from colleague, they have to retrieve that coil piece by piece to decompress their optic nerve. Now, with the flow direct converter, do you think that the principle in the past to overpack this aneurysm to achieve complete thrombosis is still there, or you just do the flow diverter and with the some kind of material that can be shrunk and disappear is only the thrombus can disappear, because putting coil fill that sac, it will never disappear, and the purpose of decompressing the optic nerve does not exist. So please, Jack, if you can answer this one and the comment from the colleague.
Yeah, I will try to answer. First of all, you have to understand that whatever you do, you cannot pack the sac of an aneurysm more than 30%. So, you know, after you cannot keep on pushing coils. So the mass effect does exist, but it's not that dramatic. Second, if the aneurysm is excluded from the circulation, it shrinks. Even if it shrinks a little bit, it shrinks. And that's enough most of the time to decompress the structure around. In addition, the swelling and the edema is disappearing if the aneurysm is excluded from the circulation. So just by the conjunction of those two phenomena, a little bit of shrinkage and a complete disappearing of the swelling, usually the mass effect is not a concern.
I think this is the mistake on some of the interventional radiologists I know from, not from in your practice. They overpack, they don't consider the 30%. And this is one that comes the problem, they never shrunk. And then we start decompressing the coil to relieve the optic nerve. I think Vladimir has some comment.
Yeah, Jacques, that was the last case I have shown, the patient who died. And we really didn't find any other explanation. Exactly, our radiologist kept this 30% rule perfectly. And still the deterioration of the vision was rather fast. And it was definitely caused by the procedure, because the patient prior to the procedure was stable for several months. So it must have been caused by the some, let's say, swelling of the cold aneurysm. So it's not 100% sure. And then,
well, you know,
in the other case, what would you do?
No. There is a phenomenon. Yeah, there is a phenomenon that we don't master and don't control, which is the triggering of the proteolytic enzyme. Sometimes, for some reason, in a big mass, even if it's partially clotted, you put a little bit of coils to favor, or at least you think that you favor the thrombosis. And then you put the flow diverter, aneurysm is gone, no feeling, nothing, and it keeps on growing and it bleeds. So, you know, the proteolytic enzyme are triggered by the amount of clot. I think the most important is to transform the red clot in a white clot, which is much less prone to trigger the proteolytic enzyme. So one of the rationale to deliver coils is not to cure the aneurysm, is to transform the red clot in a white clot because of the fibrous tissue organization. Unfortunately, it's not 100% sure, and we don't know. 20 years ago, I published a paper in which giant aneurysm were completely excluded. You have no view of the aneurysm on the angiogram, and the patient died, 2 or 3 of them died after 15 to 3 weeks, after 15 days to 3 weeks, just because of those proteolytic enzyme that we cannot master. Whatever you use, a high dose of steroid or whatever, it doesn't work. So we don't know, some cases escape from us.
So you are telling me that we shouldn't operate on this rapidly progressing vision deterioration?
No, this is not what I am saying. I am saying that it's better for you to operate. The problem, it's a bad condition. You have something which is full of coils. The shell of the aneurysm is very active. When you do an angio-MR, not an angio-MR, an MR with specific sequences to show if there is some, highlighting of the wall of the aneurysm. When you inject the dye, you can see that the wall is active. So you operate in a very hostile situation. So for you, it's not easy, but I definitely think that you better do surgery as soon as possible if you face something like that. Aneurysm keeps on growing, patient is deteriorating, go and remove as much as you can.
Okay, thank you, Jacques.
I think we are running a bit late.